It's often been said that there are a lot of good people caught in a bad system in healthcare. So I think the great excitement is that we can really move the bar and we can really do better. And there's enough evidence about models that will work. There's enough of a toolbox for a legislator that they can really find some ways, a pathway forward. Medicaid has always had a challenging time with its workforce because there are primary care shortages that have been growing for years anyway, with less and less physicians going into primary care. But then with Medicaid you have low reimbursements, you have very challenging populations that make it difficult for providers to integrate them into their practices.
We have many different subsets of population within Medicaid, and they have varying kinds of needs for benefits. So it's a very broad program that has a lot of separate categories of eligibility.
It's becoming even more challenging because of the economy, the increasing enrollment in Medicaid, and now, of course, with health reform and the impending Medicaid expansions, the pressure is really on in terms of workforce.
In terms of focused attention, where all of these issues really come to a head in almost every state, is around financing and around licensure and scope of practice. And the more legislators can get up to speed on these issues, the more impact they'll have in improving the quality of care and the fiscal standing in their states.
This idea that we're trying to push the healthcare system to be better organized and to deliver better results is really the idea. It's really important that, especially come 2014, states have enough minimum level of primary care. They're ready to handle a big influx of expansion. And importantly, they really need their workforce to be able to retool and respond to new developing models of delivering services that are more efficient and more effective.
And it tends to be that in many states, it's very few providers who are carrying a lot of the load and seeing a lot of our patients. So what we have to ensure is that we have adequate capacity of providers, not simply providers who hold a contract, but providers who are willing to see our patients.
The typical policy levers that legislators have in their sort of arsenal include licensing, so they can control who gets to come in and who gets to provide services. They can control their public programs that they influence, like Medicaid and their purchasing strategies. They can influence insurance regulation that can set standards for provider networks about kinds of people that need to be in these networks. And then they, again, have a role for educational investments and other things that they can do creatively to try and grow a workforce that's ready to serve the state.
One of the important aspects of payment reform states are doing now is looking at the relationships between services. And so when care is well delivered in primary care settings, or when states invest in electronic health records to make sure we don't pay for duplicate tests, a lot of times there are very significant savings that are very cost effective for states to invest in providing the right care in the right setting at the right time. We're experiencing provider shortages and the need to build up provider capacity. Part of this has been that in many states rates have been cut and providers have left the program, or providers that see a high number of patients are strained.
One critical ingredient is the fact that there needs to be information systems that can move data between these people so that everyone can understand how are we doing, how are we managing the care. And so these data systems and IT systems are pretty critical. So there are a lot of challenges about knitting it together and making it work.
One of the issues that sometimes is raised is whether the provider shortage in Medicaid is a function of Medicaid beneficiaries living in rural areas or inner city areas or other areas where there may be a shortage of providers in general. Many states are working on solutions to that, not simply working with federally qualified health centers and community health centers that tend to focus in those areas, but also states, and Maryland, where I work, is one of them, is looking to expand our telehealth and telemedicine programs to let providers extend their reach into new geographic areas.
States are strongly interested in managed care now and moving more and different populations into managed care because it's a chance for them to really define accountability and do better on the budget. To really say, look, we have this much to spend and we really want to pressure the system to deliver better results for the money. So it's a very value-based strategy. In some states, there have been some really purposeful efforts to look at particular types of practice and practitioners. So New York's an interesting example of convening a Medicaid redesign task force that looked at nurse anesthetists. Massachusetts took a step to really think about what were the competencies required, what were the sort of core descriptions of these jobs, and they created a certification procedure and credentials for community health workers. Colorado is another example of a state that started, perhaps on a smaller basis, a more incremental way, but established an accountable care collaborative program which tried to move in the direction of this reorganization. Arkansas is an interesting example of how, especially now, really trying to understand patient-centered medical home and information technology and all the things in front of them, they've actually convened a group and developed a workforce strategic plan.
Legislators have many tools and opportunities to help expand capacity to deal with shortage issues in Medicaid providers. First, there are many Medicaid services that don't require traditional licensure.
What I think Medicaid departments have realized is that they have the power to do it because there's so much pressure and importance on being able to really demonstrate cost-effective value for the public dollars that are being spent for these insurance programs. So I think this idea of using contracting power and purchasing power to say to a healthcare system and to providers like, okay, you know, we hear you. Primary care is important, coordinated care is important, we're going to pay you to do those things, but we're going to expect to see outcomes. And we are going to contract with those people who do really well. And if you contract with us and do really well, you'll be rewarded.
States need to be careful about reimbursement rates, need to be mindful of where they can draw federal funds. There are legitimate and fair strategies to draw federal Medicaid funds to help mitigate some of the cost burdens on states.
At the heart of this, in terms of workforce, is really changing the hearts and minds of providers.